Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12.
You will hear a local GP talking to a patient called Paul John. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Paul. How are you doing today?
Oh, hello, Doctor.
Well, I see that you've just had heart surgery for a repair of an aortic aneurysm and now have a mechanical heart valve in place.
Yes, my surgeon advised me that I set up contact with a local GP for follow-up care, so here I am.
Yes, your thoracic surgeon, Dr. Goodhands, has forwarded me your case history, but it appears you've made a very good recovery.
Well, I hope so.
Now, before we talk more about managing your recovery, I'd like to get a few personal details from you, if you don't mind.
Okay.
So, how old are you?
32.
And where are you from?
I'm from China.
Okay, and are you married?
No, I'm single.
And where are you living now? House or apartment?
I'm sharing a house with some other students.
Okay, and what are you studying?
I'm doing a PhD in IT.
So you're quite busy here in Australia.
Yeah, that's right.
And how is your study going?
Okay, I'm enjoying it, but it's pretty intense.
So a bit of a stress involved with your study?
Yes.
I see. Now a bit of information about your medical history.
Okay.
Do you suffer from any allergies?
No.
Any past surgical history?
I had my tonsils removed as a boy.
And apart from that?
No.
How about your blood pressure?
It's been high since 2009.
Is there any family history of illness?
Well, my father died of a stroke when he was 45.
I see. Do you drink?
Not much. Sometimes on the weekends.
What about smoking?
Not now, but I used to smoke about 10 to 15 cigarettes a day.
And what's your current weight?
95 kgs.
And your height?
I think I'm about 178 centimetres.
When was your operation exactly?
2 weeks ago, the 2nd of September actually.
Okay, let me check your blood pressure. Good news, it's 110/70.
Oh, good.
Pretty soon we'll be able to start weaning you off some of the blood pressure lowering medication.
Well, that'd be good.
And how is your diet at the moment? Are you being careful with what you eat?
Yes, I've managed to reduce salt in my diet and I'm trying to lose some weight.
Good. And are you doing any exercise?
No, I'm afraid to do anything too much at the moment.
Okay, I understand. But you could now start with some gentle walking or other forms of mild exercise. Just be sure you don't lift heavy weights.
Right.
And there is a very good cardiac exercise program that I'd advise you to join. It's run by the Cardiac Rehabilitation Unit at the Spirit Hospital, so I'd recommend you contact them.
Extract 2, questions 13 to 24. You hear a rheumatologist talking to a patient called Harry Davis, who suffers from gout and is attending for a medication review. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Mr. Davis, I understand your GP has referred you to me so that we can review the medications you're taking for your gout.
That's right.
So, tell me a bit about this gout. When did it start?
Well, my first serious attack was last year. My wife and I were on holiday and I woke up one morning with a really bad pain in my left knee. Well, I never thought of gout because I always assumed that just happens somewhere like your big toe, and anyway, I'm only 40. I thought it was something only old people get. So anyway, it was all red and swollen, and I decided it must be an insect bite. But I couldn't think how that might have happened, without me feeling something at the time. Or my wife suggested it might be something to do with the pills I take for my cholesterol.
Unlikely, I think.
But anyway, the pain didn't get any better. In fact, quite the opposite. I started to get frightened because I thought it might be a sign of something really serious. It was excruciating. So my wife thought I needed to get some help. So she phoned the local clinic and told them about my symptoms. They told her to bring me in. It was a good thing she was there. I was in too much pain to drive. I mean, I could only just manage to walk from the house to the car. Anyway, when we got there, the doctor took a look and said he wanted to take a blood sample. He said it might be an emergency because it looked as if it could be septicemia. So then we got really frightened, but about an hour later they came back and said no, it wasn't, thankfully, but they thought I had gout. So actually at that stage we were quite relieved.
Yeah, I can imagine.
And the doctor asked if I'd ever felt anything like it before. Well, actually, then I remembered that in the winter I play quite a bit of rugby and sometimes I'd get some soreness in the same place the day after, but I just thought I'd sprained it or something, and it would go away after a couple of days. But this pain's much worse, and it comes even when I've been resting. I've had it quite a few times since my first attack.
Right. So, what have you been taking to deal with the pain?
Well, at first the doctor at the clinic suggested I took some anti-inflammatories, but I can't say they made much difference. So when I got the next attack, I was at home and I went to my GP. She suggested I took, I can't remember the name, something?
Colchicine?
That's the one. So that dealt with the pain better, but it gave me awful diarrhea.
Yeah.
I'd never take it again. And then I had a really bad attack. I think the doctor had got to the stage where, she was already giving me really powerful medicines to no effect. So she gave me liquid morphine to take. It made me feel quite sick, actually. And I was a little bit away with the fairies, walking around not quite knowing where I was.
Right. Did you try any other sort of treatment apart from the medications?
Yes, my GP said I could try using an ice pack, and that did make a bit of difference, but you can't have it on all the time. So anyway, after that she said, let's try allopurinol, see how you get on with that. So I started taking that, but I didn't get on with it. It gave me a skin rash, so I rang her up and she told me to stop taking it, that I'd better see a specialist. So here I am. Is there anything more you can do?
Well, I'm sure we can find something, maybe a combination.
That is the end of Part A. Now look at Part B.
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25. You hear a discussion between a doctor and nurse about hypoxia and its causes. Now read the question.
Hello, Doctor. What is hypoxia and what are its causes?
Well, hypoxia means low oxygen, but is described as a deficiency in the amount of oxygen that reaches the body tissues. Hypoxia differs from hypoxemia, which means insufficient amount of oxygen in the blood. In hypoxic hypoxia or hypoxemia, the tissues do not get adequate amount of oxygen since there is a lack of oxygen in the blood flowing to the tissues. Generally, hypoxic hypoxia is caused due to inadequate breathing and other causes. In anemic hypoxia, low levels of hemoglobin lead to a decreased ability of the blood to carry oxygen that we breathe in. Therefore, the tissues get a diminished supply of oxygen. The stagnant hypoxia, or circulatory hypoxia, is caused due to inadequate blood flow, resulting in less oxygen supply to the tissues. In histotoxic hypoxia, the tissues are incapable of utilizing the adequate amount of oxygen available, despite the adequate oxygen inhaled through the lungs and delivered to the tissues. Metabolic hypoxia occurs when there is excessive demand for oxygen by the tissues than usual. Oxygen may be absorbed, transported and used properly by the tissues. However, due to a condition that raises metabolism, it is still insufficient. Sepsis is a perfect example of this. Question 26. You hear a lecture about the disease called botulism. Now read the question. Botulism is a serious illness caused by the botulinum toxin, which causes paralysis. Paralysis begins in the face and spreads to the limbs. When the condition reaches the breathing muscles, it can result in respiratory failure. The toxin is produced by the type of bacterium called Clostridium botulinum. Foodborne botulism occurs by eating foods contaminated with botulinum toxin. Common sources of foodborne botulism are improperly canned, preserved, or fermented foods. Wound botulism occurs if the spores of the bacteria get into a wound and make a toxin. Patients who get injections have a greater chance of getting wound botulism. Iatrogenic botulism occurs when excessive botulinum toxin is injected for cosmetic purposes, such as for wrinkles, or for medical reasons, such as for migraine headaches. Infant botulism occurs if the spores of bacteria enter into the intestines of an infant. Adult intestinal toxemia botulism is a very rare kind of botulism that occurs when the spores of the bacteria enter into the intestine of an adult, grow, and produce the toxin. Generally, patients with a severe health condition that affect the gut may be more likely to get this disease. You hear a discussion about gastroesophageal reflux disease. Now read the question.
Doctor, what are the different causes of gastroesophageal reflux disease?
Gastroesophageal reflux disease, or heartburn, is caused in many different ways. If the lower esophageal sphincter dysfunctions, then the lower esophageal sphincter will not close completely after the food reaches the stomach. Stomach acid will then back up into the esophagus. A hiatal hernia occurs when the upper part of the stomach is thrusted upwards into the chest through an opening in the diaphragm. This occurs due to a weakening in the diaphragm or due to increased abdomen pressure, such as with obesity. This opening is called the esophageal hiatus or diaphragmic hiatus. It is considered that a hiatal hernia weakens the lower esophageal sphincter and causes reflux. When a patient has a motility disorder or slow stomach emptying is caused due to a problem within the muscle itself, or a problem with the nerves or hormones that control the muscle contractions. Over 50% of the patient with gastrointestinal reflux disorder have abnormal nerve or muscle function in their stomachs, resulting in impaired motility. Esophageal irritation is caused when certain types of food, drink, smoking, and medications can directly irritate the lining of the esophagus. In such conditions, it makes a difference to take the pill with a full glass of water and to stay upright after taking medicines for about 30 minutes. Question 28. You hear a discussion about congenital myopathy and its types. Now read the question.
Hello, Doctor. What is congenital myopathy and what are its types?
Congenital myopathy means that a person is born with myopathy. Sometimes a hereditary medical illness does not develop symptoms until a person grows into an adult. Mitochondria myopathy is caused by a defect in the energy-producing part of the cell called the mitochondria. There are several types of mitochondrial myopathy which are caused by hereditary mutation abnormalities in the genes. However, they can also occur without any family history. Metabolic myopathy is a group of diseases caused by metabolic problems that interfere with the muscle function. Generally, this condition is caused by defects in the genes that code for certain enzymes that are essential for normal muscle movement. Nemaline myopathy is a group of disorders characterized by the presence of structures called nemaline rods in the muscles. Nemaline myopathy is often linked with respiratory muscle weakness. Central core myopathy is an inherited disease causing weakness, bone problems, and severe reactions to some medicines. Muscular dystrophy is a group of diseases caused by degeneration of the muscle or abnormally formed muscle cells. The main difference between myopathy and muscular dystrophy is that muscles do not function properly in myopathy, whereas the muscles degenerate in muscular dystrophy. Question 29. You hear a discussion about primary brain tumours. Now read the question.
Hello, Doctor. What are the types of primary brain tumours?
Well, there are many types of primary brain tumours which are named according to the type of cell or the part of the brain in which they start. For instance, most primary brain tumours begin in the glial cells. This type of tumour is called a glioma. Among adults, the most common types of brain tumours are astrocytoma tumour, arises from star-shaped glial cells called astrocytes. It can be any grade. In adults, an astrocytoma most often arises in the cerebrum. Oligodendroglioma tumour begins from cells that make the fatty substance that encases and protects nerves. It usually occurs in the cerebrum. Oligodendroglioma tumour can be either grade 2 or 3. Meninoma tumour begins in the meninges. It can be grade 1, 2 or 3. It's usually benign grade 1 and grows gradually. Question 30. You hear a discussion about different types of aspergillosis. Now read the question.
Doctor, what are the different types of aspergillosis?
Well, aspergillosis is a disease caused by aspergillus, a common mold or a type of fungus that lives indoors and outdoors. Commonly, people breathe in aspergillus spores daily without getting sick. However, people with weak immune systems or lung diseases are at higher risk of developing health problems due to aspergillus. There are different types of aspergillosis. Allergic bronchopulmonary aspergillosis causes inflammation in the lungs and allergy symptoms such as coughing and wheezing, but doesn't cause an infection. Allergic aspergillus sinusitis causes inflammation in the sinuses, and symptoms of a sinus infection are drainage, stuffiness, or headache. In the contagious aspergillosis, Aspergillus enters the body through a break in the skin and causes infection, usually in patients with weak immune system. Aspergilloma, also called a fungus ball, it is a ball of aspergillus that grows in the lungs or sinuses, but usually does not spread to other parts of the body. Chronic pulmonary aspergillosis is a long-term condition that lasts for about 3 months, and which aspergillus can cause cavities in the lungs. 1 or more fungal balls may also be present in the lungs. Invasive aspergillosis is a serious infection that usually affects patients with weak immune systems, such as organ transplant or a stem cell transplant patient. Invasive aspergillosis most commonly affects the lungs, but it can also spread to other parts of the body.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a geriatrician called Dr. Claire Cox giving a presentation on the subject of end-of-life care for people with dementia. You now have 90 seconds to read questions 31 to 36.
My name's Dr. Claire Cox. I'm a geriatrician specialising in palliative care. My topic today is an increasingly important issue: end-of-life care for dementia patients. The care of dementia patients presents certain problems. Dementia is a terminal illness and is the third highest cause of death in Australia. But dementia is different from other such conditions. It has an unpredictable trajectory, and there can be difficult issues around patients' mental capacity, decision-making and communication. But, in spite of an equal need for palliative care services, dementia patients don't always fit the traditional model of such care. Families often suffer distress because they feel unable to ensure that their loved one's wishes are being respected, or just don't know what that person wanted because the discussion wasn't held early enough. There is therefore a clear need for well-funded, patient-centred palliative dementia care that's available when and where it's needed. I do a lot of work with Dementia Australia, an organisation which represents the needs of Australians living with all types of dementia, and of their families and carers. It also campaigns on dementia issues and funds research. Dementia Australia decided it was the right time to examine the issue of end-of-life dementia care from the perspective of the consumer as well as from that of the healthcare professional. It's a timely initiative. We have plenty of anecdotal evidence but not enough hard facts about what's going wrong and why the system's failing. But the current situation isn't all bad. Despite the issues I've mentioned, I've heard some wonderful examples of how palliative care has made a big difference to people's lives. Things can obviously go badly wrong if this isn't handled well. But in the right circumstances, people with dementia can reach the end of their lives peacefully and with dignity. Dementia Australia commissioned researchers to conduct a survey on the end-of-life issues affecting dementia patients. The survey covered both care professionals, that's doctors, nurses and others working with dementia patients, as well as family member carers. The interest was overwhelming, with more than 1,000 responses from around Australia. But what do the results tell us? Well, the initial results confirmed what we've heard about access to appropriate end-of-life care. It was obvious immediately that there was a striking gap between the perceptions of care professionals and family member carers about end-of-life dementia care. For instance, while 58% of family member carers said that they didn't have access to palliative care specialists and 68% didn't have access to hospices, 3/4 of care professionals indicated that people with dementia in their area do in fact have access to palliative care. This begs the question of whether consumers, that is, patients and family member carers, might not be aware of services that are available. Another notable finding of the survey was that care professionals often lack knowledge of the legal issues surrounding end-of-life care. Some reports indicate that care professionals are at times reluctant to use pain medications, such as morphine, because of concerns about hastening a patient's death. However, access to appropriate pain relief is considered to be a fundamental human right, even if death is earlier as a secondary effect of medication. Our survey found that 27% of care professionals were unsure about this, or didn't believe that patients are legally entitled to adequate pain control, if it might hasten death. So perhaps it isn't surprising then that 1/4 of former family member carers felt that pain wasn't adequately managed in end-of-life care. This lack of awareness extends beyond pain management. The statistics on refusing treatment were particularly shocking. Almost a third of care professionals were unaware that people have the right to refuse food and hydration, and 1 in 10 also thought refusal of antibiotics wasn't an option for patients in end-of-life care. How can we ever achieve consumer empowerment and consumer-directed care if the professionals are so ill-informed? There's a clear need for greater information and training on patients' rights. Yet over a third of care professionals said they hadn't received any such training at all. It's obvious that end-of-life care planning is desirable. Discussing and documenting preferences is clearly the best way of minimising the burden of decision-making on carers and ensuring patients' wishes are respected. Advanced care planning is essentially an insurance policy that helps to protect our patients in case they lose their decision-making capacity. Even though a patient might believe that loved ones will have their best interests at heart, the evidence shows that such people aren't that good at knowing what decisions those they love would make on complex matters such as infection control and hydration. So before I go on to...
Extract 2. Questions 37 to 42. You hear a hospital doctor called Dr. Keith Gardner giving a presentation about some research he's done on the subject of staff-patient communication. You now have 90 seconds to read questions 37 to 42.
Good morning. My name is Dr. Keith Gardner, and I'd like to talk to you today about some research I've been involved in concerning something that affects all health professionals: staff-patient communication. Now, firstly, let me reassure you that in feedback, patients seem positive about the way information is communicated to them. But I recently decided to explore the issue in more detail when I was in a hospital with a patient and witnessed for myself what can result when a healthcare professional assumes they've made themselves clear to a patient, when in fact they've been anything but. Luckily, I've had very few complaints made against members of my team, but the potential is certainly there. So first, let's start by looking at a typical hospital admission for an inpatient, and the first communication they have about any procedures they are to undergo. On arrival, a patient will complete necessary paperwork. Various staff will talk to them about their treatment during their stay, which is designed to reduce patient anxiety. However, from some patients' point of view, this interaction can seem very complex and difficult to take in, especially at a time when they're not at their best, physically or mentally. So it's doubly important to check that any communication has been understood. Now, to illustrate what I'm talking about, let's take a hypothetical situation. I often use this because it highlights the potential consequences of poor communication. A man in his 80s is admitted to hospital, despite his protestations, with ongoing severe back pain. On investigation, it's found his cancer has spread. The outlook is poor, and further compounded by his becoming depressed and refusing to eat while in hospital. A feeding tube is inserted, a procedure which the patient complies with, but which his family members query. The doctor on duty updates them, assuming they're aware of the severity of the patient's condition, when in fact no such prognosis has been shared with them. An extreme case, but a plausible one, nevertheless. In order to find out exactly what inpatients felt about the service they were receiving in this hospital, we conducted a patient survey. The questions were carefully targeted to capture patients' opinions about the effectiveness of the communication they'd been involved in during their stay. The survey questioned patients on both what they had expected prior to admission and what their stay was really like. These two scores were then used to calculate what's called a gap score. The survey also included questions to measure the patient's behavioral intention, that is, how willing they would be to return to the hospital for treatment. Patients completed the survey themselves, and results were then processed with the help of medical students. Now, the survey produced some interesting data about communication, including both praise and complaints. Clearly, in a hospital situation, staff are dealing with confidential and sensitive information, which must be communicated in private, a situation which can be difficult to achieve in a large and busy hospital. However, we scored highly on that point, and we were also pleased to note that staff did manage to communicate in a manner that treated patients with dignity and respect. Of course, staff also have to ensure patients fully understand what's been said to them, and this last point's where we received the most negative feedback. Both patients and relatives noted a tendency for professionals to resort to the use of jargon and complex terms when explaining both diagnoses and procedures, which left some patients confused. However, patients were generally satisfied with the information about any follow-up treatment provided after discharge. Also, once we'd sifted through all the results, a clear pattern began to emerge regarding the care given by nurses, which I found particularly interesting. I'd assumed that having a number of different nurses attending to a patient during their stay was a good thing, because you need enough staff to cover the various shifts and attend to patients' needs. What I certainly hadn't expected, though, was for patients to say they felt their recovery was faster when they had to communicate with only a small number of nurses. In other words, when they were surrounded by familiar faces. The findings aren't conclusive, and more investigative work needs to be done on a bigger sample, but it's certainly food for thought.
I wonder. How head injury can lead to a condition like this?
I realize your anxiety. Definitely, I will help you to sort it out. But before moving further, would it be okay if I can ask you some questions?